In this video, we'll be discussing hepatic portal hypertension and its effects on the body and the abdominal vasculature. In response to demand, the body must direct more oxygen and nutrients in the blood to different regions of the body, and when necessary, temporarily curtail the supply to a less essential region. The processes of vasodilation and vasoconstriction provide powerful control mechanisms of the blood flow. In the pathophysiology of this vascular alteration, mesenteric splanchnic vasodilation plays an essential role by initiating the hemodynamic process. Splanchnic vasodilation is the result of an important increase in the local and systemic vasodilators and the presence of a splanchnic vascular hyporesponsiveness to vasoconstrictors. The splanchnic circulation is the main vascular bed responsible for the reduction in vascular resistance in the portal hypertensive hyperemic state. An increase in splanchnic blood flow in portal hypertension is the result of a hyperemia with a marked vasodilation of the arterioles in the splanchnic organs, which drain blood into the portal venous system. The increase of blood volume in the splanchnic organs and the subsequent increase in portal venous flow maintains and aggravates the portal hypertensive syndrome. Venous blood is returned to the circulation by one of two systems, the portal system or the systemic system. The portal system being a system draining blood from the spleen and all the gastrointestinal organs between the distal esophagus and the rectum. This mesenteric portal blood is directed by the portal vein to the liver, where it is filtered before returning to the heart by the inferior vena cava. In contrast, blood from the rest of the body is transmitted by the systemic veins, directing blood back to the heart by the superior and inferior vena cavas. Because this systemic circulation is often referred to as the caval system, we will use the two terms systemic and caval interchangeably, since it is likely that you will encounter both in the clinical setting. Because the circulatory system is continuous and closed, there are areas where the systemic circulation and portal circulation are physically connected. But in healthy people, there is little blood exchange between these two systems, since the pressure in each are about equal. A portal system anastomosis refers to abnormal venous return, in which the blood flows the wrong way through these connections. In most instances, portal systemic anastomosis, blood from the portal system should flow towards the liver. Instead, avoids the liver by flowing backwards to join the systemic circulation. Why does this blood avoid the liver? Because of a condition called portal hypertension. An increased production or activation of the vasodilatory mediators and systems, and a decreased vascular reactivity to vasoconstrictors are responsible for the splanchnic hyperemia. In addition, increased angiogenesis probably collaborates to increasing the splanchnic blood inflow. Portal hypertension means that the pressure in the portal veins is abnormally higher than the pressure in the caval system. Portal systemic anastomosis are important indicators of liver dysfunction and can lead to swollen veins called varices that may cause clinical problems. Insulin resistance causes red blood cell aggregation, causing problems with circulation in addition to being a common contributor to liver dysfunction. Bacterial infections and endotoxemia are associated with a failure to control abnormalities in coagulation, vasodilation of the systemic vasculature, early variceal bleeding, and worsening of liver function. Splanchnic arterial vasodilation also contributes to portal hypertension. Multi-organ dysfunction and failure results from a complex interplay where the systemic spread of bacterial endotoxin represents the primary event. The consequent activation of the innate immune response triggers endothelial molecular mechanisms responsible for arterial vasodilation and also jeopardizes organ integrity with a storm of pro-inflammatory cytokines, chemokines, reactive oxygen species, and nitric oxide production. In this video, we will discuss the three common types of portosystemic anastomosis, which are esophageal varices, caput medusa, and internal and external anal rectal varices, also known as hemorrhoids. Let's begin with esophageal varices. Blood from most of the esophagus does not pass to the liver, but is transmitted to the heart by the caval system. However, the distal portion of the esophagus does send its venous blood inferiorly to join the portal system. In the region where this transition occurs, there are venous channels that connect the portal and caval systems. Under normal circumstances, there is very little backflow through the interconnecting channels. Insulin resistance is a risk factor for esophageal varices. However, when portal blood flow through the liver is impaired and portal pressure becomes high enough, and some portal blood will be shunted to the lower pressure caval system through the interconnected channels, thus forming a portal anastomosis. Portal blood will continue to be sent directly to the caval system until the pressure in the two systems becomes equal again. If a large amount of portal blood is shunted this way, it can cause the smaller systemic vein to dilate due to the increased parasympathetic vasodilation neurotransmitter, serotonin, entering the systemic blood supply and form varices. The varices are weakened segments of the vein due to the fact that their walls are stretched and thinned. Varices can form both on the external surface of the esophagus and internally under the esophageal mucosa, which protrude into the lumen of the esophagus. Portal hypertension anastomosis occurs in other areas of the body. Regardless of the region, the process is the same. Increased pressure in the portal system shunts unfiltered portal blood to the systemic veins, and there is a subsequent increase in the volume passing through the systemic veins. This unfiltered blood sends unprocessed proteins, food particles, and bacteria to the systemic circulation not suited to handle the influx, causing the formation of varices due to the influx of vasodilatory neurotransmitters and chemokines. Now let's look at the two other portal systemic anastomosis, caput medusa and anal rectal varices. Caput medusa, or Medusa's head, refers to swollen and subcutaneous veins on the surface of the abdomen. They can radiate out from the umbilicus, but they can also be seen subcutaneously. Caput medusa results from the portal venous hypertension in the veins that spread out into the subcutaneous systemic veins on the abdomen. Anal rectal varices resulting from portal hypertension are not usually painful, since they most often occur in areas with visceral innervation. The viscera are not endowed with epicritic sensibility that enable the perception of slight differences in the intensity of stimuli, especially touch or temperature. The viscera only have deep and propathic innervation, sensing pain, pressure, heat, or cold in a non-specific manner. By this fact, Head explains the referred nature of visceral pain, for when a part is once endowed with epicritic sensibility, the pain is no longer referred. If a person is experiencing pain with anal rectal varices or external hemorrhoids, It is located in an area innervated by sympathetic nerves around the inferior and middle rectal vein. Or this may be due to a damaged ganglion of impar where propathic parasympathetic nerve fibers have been replaced by the epicritic sympathetic fibers. Medical treatment to relieve portal hypertension involves surgical removal of the hemorrhoids or manipulation of the blood vessels to divert the portal blood directly to the systemic veins that can handle the load. Functional splanchnology intervention involves nutritional support for the restoration and rehabilitation of the neuroendoimmune supersystem control of the vasomotor system, in addition to support for the restoration and rehabilitation of the gastrointestinal sequencing. This in turn assists in restoring long-lasting control of the microbiome and the digestion of food. This is done in conjunction with support for insulin resistance. While it may be tempting to use liver and colon cleanses for patients suffering with hepatic portal hypertension, until the vasomotor control is restored, blood will continue to pool in the mesentery around the weakest organ, creating an imperfect environment for continued dysfunction. This requires both nutritional support and visceral manipulation techniques to restore and rehabilitate the abdominal viscera. A further benefit to this would be the reduction in referred viscerosomatic pain.